How's your week been going, Christian? I think it's been like 2 weeks since we've done one of these. It's been a little bit.
Yeah, we had last week off because you were somewhere, but I was back home in Chicago.
Yeah.
Went to an AC/DC concert, which was
Hell
insane.
yeah.
Insane. They still got it,
Yeah.
dude. They're still killing it. So that was a lot of fun. But this week was good. Yesterday was our first live day doing flexed metal physical therapy in person. And so I had three patients
Nice.
yesterday, and it was great.
Perfect.
It was perfect. Yeah. I
There you
think
go.
everyone had a good experience. One of the guys I had met at a climbing competition a few weeks ago when I did some tabling and some marketing, and he had wrist pain from like 6 years ago when he was in a mosh pit, and he got his wrist hyper flexed, and he felt a pop
Hmm.
somewhere in his wrist. And ever since then, he's had full range of motion, but if he weight bears on that wrist with like a bench press or a push up, he gets pain, and he has a little bit of swelling in his anatomic snuff box, so like the base of his thumb.
Yeah. Yeah.
And
Yeah.
through our eval, he was really tender on his scaphoid, and all resisted testing and stretching and like ligamentous tensioning was unremarkable, no problem.
Yeah.
But if you made him compress his wrist with all sorts of different positions, and I pushed on that scaphoid, whether it was on the back of the wrist, the front, the side, it all freaking hurt. And so I'm like, dude, you might have a long-standing scaphoid fracture.
Yeah.
I don't know for sure, but we need to get you an x-ray because like if you let this go forever and ever, there could be problems.
Yeah.
So that was a fun one to see. Do I think he has a scaphoid fracture? Maybe, possibly, hard to say, but it doesn't really make any sense for it to be a ligament or a muscle or tendon, given that it was only compression that got him.
Yeah, man. Well, hell yeah, dude. Right on. That's awesome to hear. I'm glad that it's day one went well, and sounds like you had some pretty interesting cases over there. That kind of fits what the a little bit of what the podcast is going to be about, I guess, talking about diagnoses and labels.
That's one way to transition.
That's one way to transition, right?
Well, I think it was last week you sent me a text with some kind of a screenshot of a post from Instagram talking about
Yeah,
this article. The worst pain is an unexplained pain, which is it's a viewpoint, or like it's an opinion piece basically that's published
opinion
in a
piece, yeah.
journal. It has citations and all that, but it's an opinion piece.
But like, so on, I guess technically it was on X or Twitter, but it was a post from JOSPT, which is kind of a more respected journal, I guess, within physical therapy in terms of what they post. They usually post pretty credible stuff. Well, this time they posted this kind of narrative piece on pain and diagnosing and kind of their standpoint on it. And one of the people that I really like to listen to and read from, and you do as well, Christian, who is Greg Lehman, he commented on the post, kind of pushing back a little bit on the narrative that they had. And I sent it to you because I honestly just think that most of the time when he tweets stuff, I think it's just funny. And so I sent it to you because I'm like, this is kind of funny to me. And also like, what are your thoughts on it? And then that sparked kind of this conversation between the two of us of what do we think is our opinions on this piece that JOSPT put out, and do we agree with what Greg said? And we had a good phone call about it, and we were basically, hey, why don't we turn this into a podcast? Because we think it's going to be um, pretty insightful stuff. At least we think so. And yeah. So, anyways, that is the kind of the basis of what or why we're doing this podcast. Not going to be a whole lot of like advice on how to treat or what to do, I guess. It's going to be more of our opinion when it comes to the behind the scenes stuff of physical therapy. So they're kind of the title, what they're saying is that like the worst pain is unexplained pain. What do they mean by that? It's pain that we're admittedly not giving a specific or somewhat specific terminology to. And so this would be when we say non-specific low back pain, right? Could mean so many different things. But based on what we know with the research, that is kind of the most technically sound way to put it. And this narrative is saying, well, hold on, that can be detrimental at times. Things like increased fear, lower self-efficacy, increased like what's called like repeated medicalization, different things that we don't really want patients to experience. And so they offer up some different viewpoints on it. But Christian, what are your thoughts just kind of off the bat, 10,000-foot view of what the article is all about?
Yeah, it really is all about diagnostic labels. So, what are we calling the pain that you have? Our job is to try to give you the best possible label that we can give you because we want it to be really accurate and make sense. For years and years and years, and even now, we try to give you very pathoanatomical diagnostic labels like rotator cuff tear or lumbar disc herniation, for example. And we'd like to say that those issues, those pathologies are the source of your pain, especially if we can find it on imaging like an X-ray or an MRI, then we definitely will say like, this is your problem. The issue with those diagnostic labels is they aren't always true in that a lot of times when we go and do a scan on someone's low back, when they're in pain, we're going to find that they have arthritis or a mild disc herniation or something like that. But if we do those same tests on people who don't have pain, we're just as likely to find those same kinds of things. So it's very difficult for us to say, oh, this is 100% causing your problem because it can be in literally anyone. And the older you get, the more stuff you find on these scans. And so a lot of pushback has happened in the physical therapy world where we're like, maybe these very blunt diagnostic labels aren't that helpful because they're not really the most true. They aren't the most accurate terms to give these. And so we, like Eric was saying, we're giving people these terms like non-specific low back pain or rotator cuff related shoulder pain or greater trochanteric pain syndrome because they don't point to a single structure. For example, in the low back, it's not saying your pain's due to a herniated disc. It's saying your pain's non-specific, meaning like we can't find a single structure that's causing your problem. And it could be due to a ligament or a tendon or a muscle or your joint or an irritated nerve, all sorts of things. We don't know for sure, but we know how to treat you. And so the thought is that if we give people more accurate, all-encompassing terms like syndromes and whatever else, that it'll overall be a benefit for the patient because they don't start to have all these negative thoughts and feelings around scarier words like tear and bulge or herniation. And these more accurate terms are going to lead to people just being better overall. And so that's my answer to you and your question, Eric. But yeah, that kind of brings us to our thoughts around what's the good and bad of that shift in terminology, and if we even agree with it. But where do you stand now?
Like we talked about before, for me personally, it doesn't, I guess, matter a whole lot. It's more of what's going to get the patient the best results, right? Like if a research article came out tomorrow and it unequivocally told us that like if we diagnose people based on colors, like you have a red diagnosis and you have a pink diagnosis, and that got them better than anything else that we could offer them, like, dude, I'll start calling people a blue diagnosis if that means they get better. I don't care what I'm telling patients in terms of the diagnosis, right? So if it's, and there is a point to this, I'm not just going off on colors right now, but because it doesn't change a whole lot what our plan of care is going to be, right? If I tell you, oh, you have subacromial pain syndrome, or if I tell you, I think you have a, supraspinatus, left supraspinatus sprain or strain. And then those two different diagnoses, one is more broad, one is much more specific, doesn't change a whole lot in terms of how I'm going to approach this issue for you. I'm going to give you an initial plan and progress it over time, modify your activity, educate you on pain, and based on how you react to the initial treatment, we're going to modify, progress, or regress on what we're doing until you get better and reach your goals. And so I would say the majority of time, those are the cases that we would see in physical therapy. Now, there are other moments where, you want to be very specific with your diagnosis. And for example, just going back to the vestibular world, right? If I just said, oh, you have left-sided BPPV, just left-sided, doesn't matter. You're dizzy, it's from the left side. And if I was like, that's not going to change my plan of care, well, BS to that. It's definitely going to change my plan of care based on a specific diagnosis. Because if you have left posterior and I'm treating you with left horizontal treatments, you ain't going to get better. And so, you know what I mean? Like, it's like that needs a very specific diagnosis, and the plan of care does matter on what we're doing. There are, I would say, majority of people, if I think that you're going to like it better if I give you a very specific diagnosis, And then that's likely the route that I want to go down, right? Now, if you're someone that I think is if I use words like, you know, strain or sprain or bulge or or tear, whatever it is, right? Like these much more contextual type words. If I use those in the diagnosis and I kind of feel out the eval, I'm like, man, if I use that, this patient, their alarm system is going to start ringing loud, right? And so I'll generally keep it a little bit more vague then, and use something more general and use much more lighter words that aren't going to make their alarm system go off, because it doesn't matter at the end of the day, because the plan of care is likely not going to change a whole lot based on what specific words I use at that time with that patient. And so I know that you have some thoughts on that as well, Christian. And so I don't want to, keep going and say all the things. But the point is that I'm not too concerned about the diagnosis if it's super specific or very general, because I think it depends on the patient in front of you and what they need or what they want to hear in terms of something very specific or something very general. Because like I said, majority of the time, plan of care, not going to change that much. Unless it's something specific like in vestibular therapy, you need a specific diagnosis to get them better. Otherwise, they're not going to get it.
Yeah, and the crux of the issue with this article is which way is best? Should we be saying things like, for the shoulder, for example, you have a rotator cuff tear, or you have rotator cuff tendonitis or tendinopathy? Or should we be saying things like rotator cuff related shoulder pain or subacromial pain syndrome? Whatever label you want to give it, our job is to figure out which one seems to get the best results.
Yeah.
And I agree with what you're saying, where it really depends on the patient and which words seem to resonate with them the most and what's going to get them to do the things that you need to do, because you're totally right. It doesn't matter what the term was, whatever 5 terms I just said, I'm going to treat you basically exactly the same. And I will treat you exactly the same. Doesn't matter what the word is, because when it comes to getting people better, it isn't that we have a diagnostic label and then we say, oh, this is the label you have. I give you X, Y, or Z treatment for that thing. It isn't how it works. We have principles or guidelines or systems in place that we use to get you better. So we know that if you have a shoulder thing, one major principle or system that we put in place is just getting you stronger all over that shoulder. We know that if you do that, whether it's a tear or bursitis or quote unquote impingement, people get better over time more often than not. Not always, but the label you give it doesn't really change what we do. Now, that's on our end as physical therapists. And the authors of this article, if I interpreted them correctly, they weren't saying that we should get away from terms like rotator cuff related shoulder pain, which are very vague and kind of meaningless. I think they were saying that we should keep doing that. It's just when you do that, provide more context. And I actually thought they were going to go in a different direction. I know you and I spoke on the phone about this article a couple days ago, and we were thinking like, yeah, they're probably going to recommend that we move away from these really vague syndrome type terms and actually get more specific again. But I don't think they said that unless you read something different.
No, I think I would agree with in terms of, I think they were just advocating for more, like you said, context around the scenario. And again, I would just go back to, I think it's patient specific. I think if you think that patient needs that context, and then keep giving them some more information as you go along. But if it's someone that you think is going to do better, keeping it more vague, keep it more vague and go from there. It's kind of, it's a little bit of just playing that psychological game with the patient in a good way, not trying to say like manipulative or anything like that, but it's using communication skills, it's using what you know about fear avoidance and pain catastrophizing and like all these other things that like we're trying to stay away from based on how we talk, right? So that's where I'm saying it's a little bit of that psychological game with the patient so that they can be set up for the best results.
Yeah, so I'm going to make my opinion clear here. I think those very syndrome type terms like non-specific low back pain are actually not that helpful. This is my opinion. I totally understand where they're coming from, and I agree with the overall sentiment. It's just that I don't think they work from the end user's perspective. Meaning, all I'm trying to do as a physical therapist, as a clinician, is get you, the patient, better. And everything that I do is meant to help you. It's not meant for me to be more correct or accurate in the things that I say or do, like technically correct or accurate. I just need you to get better. And I'm going to do all the things that I know are going to lead to that based on the best evidence that we have. But I'm also going to meet you where you're at and ensure that everything that I'm communicating with you makes sense. And I think that just comes down to fundamental human nature, where we as humans need clear labels for things. It's a human nature thing. It's a cultural thing. We just love naming and categorizing stuff because it helps us make sense of our world. And the words that we use, the diagnostic labels we give you, they carry weight. They have meaning. They evoke emotion. And we as healthcare providers cannot ignore that. We have to always be trying to use language that you use every day, and language that you've been using your entire life, and that makes sense to you right now. If we go and start changing all these words on you, you don't have any context for that. And it just makes us look stupid because we're not able to help you better understand your problem. When we articulate concepts to patients in ways that they don't understand, they get frustrated and they might not trust us. And if they're frustrated and they don't trust us, are they really going to do what we know they need to do to get better? Maybe not. It's just, it decreases the likelihood of success. And I always want to do the opposite of that. But other thing I want to say is that you got to think about, speaking for Americans, the average American reading level. You know, a quick Google told me it was at 8th grade, which I don't know if that's true. I've been hearing things like 5th grade for a long time as well. But like, when you were in 5th to 8th grade, how many big words did you know? If I start throwing out words like subacromial pain syndrome, like, what the hell does that mean? It means nothing.
Yeah.
And then also from some government sites or sources, it said something to the effect of 9 out of 10 Americans have trouble understanding the words used in healthcare. They don't know the words on their pill bottle. They don't know the words on their imaging. And so if you're using a bunch of terms that people don't understand, or you as a healthcare provider are not taking the time to simplify that medical jargon and make it more approachable, I think we're doing our clients a disservice. We're not really helping them much if they don't know what the hell we're talking about.
Okay. Yeah. So we're talking about, your opinion is that you're, I guess, not all bought in with the non-specific low back pain label, like these more general vague terms, and that, using things like subacromial pain syndrome or kind of these more, I guess, not well-known phrases can make people frustrated and not know what's going on at times. And that could possibly lead to less adherence, poor outcomes, etc. I guess that's kind of the train of thought. Am I summarizing or kind of understanding your standpoint on that, Christian?
Yeah, and it's not just a thought or opinion. This is something that I hear from patients every single day, where they're just trying to make sense of their healthcare and they don't know what the hell these words mean. And if I start using ones that are different than their doctor or their NP or their PA, who looks bad in that situation? It's not the doctor.
Yeah.
It's me.
Yeah. No, yeah. I agree. I mean, I agree to, I would say, an extent. I feel like, and the only reason I would say I agree to an extent is because, yes, I agree. I've had conversations where I say things that are very vague and I can feel the patient be like, what the F does that mean? Or what the hell are you saying? Like, why are you telling me something different than my doctor just told me? Or why is it so vague? Like, do you not know what you're talking about? That type of thing. And then we have to have a good 10-minute conversation on like the history of what I'm using as a diagnosis versus what they're using and try and educate the patient. When in reality, the patient probably didn't need to have that type of conversation. So like from that perspective, I have had run-ins where like I would agree. Sometimes I think these really vague, non-specific things can be more detrimental in terms of how the patient views us as physical therapists and their understanding of what's going on, because it can bring about these negative feelings, emotions, and thoughts. So I would agree from that standpoint. I would also say, and this is why I think that each patient's different and you have to approach each patient different, because I've also had patients where they come in and I'll be like, you have non-specific low back pain. here's a 1 minute spiel on what that means. And the patient goes, yep, understand it, got it. And then at the end of the day, I tell them, you don't have to be concerned about this. Like, overly concerned about this. Like, we've checked the boxes. We know this isn't a progressive thing. And we know this isn't a medically emergent thing. And telling them that, like, yeah, it's non-specific, but, like, keeping it kind of nonchalant, lighthearted, etc. And I've had many patients that go, oh, got it. Okay, now I can breathe a little bit lighter, and I don't feel like I have this heavy weight on my shoulders that my back is going to fall off tomorrow. Those patients do great with that label and that diagnosis. And so I've seen it both ways, but I understand where you're coming from, Christian. And that's why I say, like, I've gotten to the point now where, like, I definitely vary my diagnosis based on the patient and kind of reading the room with them, right? And kind of knowing, like, oh boy, I better give something a little bit more specific here. Or, you know what? I think this patient's going to do well if I just keep it more of that vague, non-specific type thing. Anyways, what is your thoughts on that when it comes to patient interaction and diagnosing that way? Do we have to be rigid and say, nope, if we're going to do it one way, we got to stick to it with every single patient? Or are you in agreement with what I'm saying in terms of, hey, we can vary this stuff up?
I agree with you. I'm not saying that we should not use those terms like non-specific low back pain. It's a matter of what is the patient coming to you with? Did they already go to their doctor and have an image? And the doctor said, yes, you have low back pain because you have this bone spur in your facet joint, and that's why you have pain. Go to physical therapy. It's like, okay, now the patient comes to me and they're like, yeah, I have back pain because I have this bone spur on my x-ray. How are we going to make that better? And it's like, okay, when people come like that, it's like, all right, I got to lean into that a little bit. It's not helpful for me to say, your doctor's wrong. We don't actually know if that's causing your problem. I do provide them the context of, yeah, that makes sense. That certainly could be a source of your pain, but you should also know that you definitely had this bone spur before you had low back pain. It doesn't come out of nowhere. And loads of people that don't have any back pain also have bone spurs in that same area, and they might be fine forever. And so it's reasonable to think that you had this bone spur, didn't have pain, and now you have pain, that we can get you back to that pre-pain status, even with that bone spur, because you've already been there. That's a realistic thing for us to do. And also, I can't say with confidence that's causing your problem. You could have also had some kind of sprain or strain of your ligaments, your muscles, your tendons, whatever. So to me, that spur is not really a huge issue. We're going to focus on what types of things, what kinds of movements, activities, postures cause your problem. Then we're also going to put in place all the systems we know that are effective for you, like adding in some manual therapy for the area, doing tons of exercise that fits your preferences and your barriers and what seems to really work for you in this moment. And if we do all those things, you're going to get better, whether or not that bone spur really changes on imaging. But
yeah,
I just tailor my message to the patient and what they come to PT with. A lot of them that come to us without seeing their doctor, well, that's where I'm like, all right, your back pain, I can't find any major, glaring, serious, or sinister reason why you have that pain. You certainly did something. Maybe you sprained or strained some of those muscles or ligaments, but you're going to be good. I don't see anything here that's alarming to me. And if we do X, Y, or Z, you're going to get better.
Yeah.
So it all depends on what they come to me with.
Yeah, I would agree. That's a good point. Yeah, that's when you get all excited when patients come to you first without seeing another medical professional, and they're just like this non-biased, malleable individual where it's like, perfect. We can tell you exactly how I feel and how I think about this without having to worry about possibly contradicting anyone else.
Well, and if you contradict other people, like I said earlier, people mainly trust the first thing they hear. That's their anchor. That first diagnostic label they get, that's where they're going to be starting from. That's in their head. That's when they trust the most, especially if it's coming from a person of authority that has greater authority than you as a therapist, such as their physician or their neurosurgeon or something. And so if you're trying to help this patient, you got to play ball. You got to recognize that they don't know you. They already have these other terms floating around in their head. They probably trust those terms more because they probably make more sense anyways. If the doctor says, yeah, you have arthritis, you have your bone on bone, that's why you hurt. Okay, like you as a therapist, when you have that patient, you have to play ball, so to speak, and navigate that conversation really well while acknowledging that doctor's opinion and that patient's perception of that opinion and now their own formed opinion, but then also try to edge in some different ideas or different terms that are more likely to lead to success and help you de-escalate that situation.
Right.
And when I say de-escalate, I mean like it is important for everyone to know that the words you use to describe an issue matter psychologically. We have tons of research on this where the scarier sounding words you use amplifies people's pain. It makes them take longer to get better. It decreases the chance they'll get better. And so words in rehab, in medicine, really do matter. It's just, can you change those words very quickly, or should you? Because you can also cause tons of other problems when you go changing stuff too much.
No, yeah. And I think that kind of like what you're alluding to, like words, that those things matter. They definitely do. And like you said, there's research to back that up. And I don't want to speak for him, but I would be curious if that's kind of the direction of where Greg was coming from in that tweet. I'm just speculating. I'm not putting words in his mouth. But, because he pointed out like movement coordination deficit and how that's a made up term. And he doesn't agree with that. And that was what I found kind of funny, by the way.
Well, I think he said he agrees with those terms and that we should keep using them and not get away from them.
In terms of, and so, which I thought was just kind of funny. That's why I sent you in the first place. But I think, anyways, going on beyond that point though, that the words that we use in that context, that they hold weight, that they matter, kind of what we say and what the patient thinks about. And kind of just bringing it full circle based on, back to what the article is all about. And that's that the worst pain is an unexplained pain. And that how we explain or how we say things or don't say things can have a big effect on patients. And just kind of going back to what I've said a couple of times before now, I really think it's patient dependent, in that, we've both talked about the plan of care, et cetera. But I think that a really good therapist can navigate these conversations well, and you can have person A and person B with the same pathoanatomical features, but you might tweak what you say to each person and be a little bit different, and each person is still going to get better, even if you said two different things.
So I want to stay on the topic of functional movement labels, which are labels that we use to describe an issue without being overly specific. So let's stay with neck pain. A very specific label is going to be neck pain due to a disc herniation or facet joint arthritis. But if you move to functional movement labels, you'd say something like neck pain with radiating pain, or neck pain with mobility deficits, or neck pain with movement coordination impairments. My problem with these functional movement labels is they literally mean nothing. I, when I first was exposed to them in, maybe it was grad school, but definitely in 2018 when I was studying for my orthopedic clinical specialist certification, those labels were everywhere. We had to know them all. We had to memorize them, and we had to think about patient problems in that context. And it's just like, they're just so dumb to me.
They're still in there now, by the way. Or at least
I know they are. And I know people love them and we're supposed to be using them. I just think, like, from going back to the end user thing, the patient doesn't know what that means. They literally don't care. It doesn't fit any of the context they've had from when they were born to now of how we name things in medicine.
Yeah.
And they're very vague. And I just don't think that's really constructive, because whatever the business or service or product you have is, the name must be recognizable, clear, and easy to understand. So what makes more sense as the patient? Your diagnosis is neck pain with movement coordination impairments, which means that the injury you sustained has altered the way your body perceives and coordinates movement. Or your diagnosis is a neck strain. Your muscles are really sore, tight, and weak because they got overstressed. We need to address all three of those things for you to feel better, and here's how we're going to do it. Those are two ways that you could explain someone's neck pain to them, and I'm very much in favor of the second one, where you're just way more direct. Something got sprained or strained, or something is irritated or aggravated or overworked, because those words are simpler. People already know what those words mean, and they just better convey to the patient what's going on. And then, of course, that makes it easier for you to bridge to, here's what you do about it.
Yeah, no, and I would agree. I think I do that probably more times than not when it comes to I might say kind of like what you went into detail about there, just because like it's like, hey, if you went and looked at your note after today, right? The PT note on your online medical record, like here's the diagnosis I'm gonna put down as like the PT diagnosis, but like this is what we mean or this is what we're speculating based on that, right? Giving them a little bit more meat to chew on. Yeah, I don't know. I'm trying to think of a good like analogy of it's almost like if let's say your sink wasn't draining and a plumber came over and he just looked at the sink, ran the water and it was plugged up and he just went, "Oh yeah, your sink's not draining." And you're like, "Well, yeah, I already knew that."
Yeah, your sink
Like,
has draining deficits.
yeah, like if someone comes in with neck pain and they're like, "I can't turn my head to the left." It's like, "Oh, I figured it out, dude. You have neck pain with mobility deficits." I already knew that. It's like the same thing if a plumber comes in and you're like, dude, I'm paying you $150 an hour to fix my sink. What are you going to do about it? He's like, well, I don't know, man. Somewhere between here and the city sewage system, there's a problem. Yeah, I'm paying you to figure that out for me. You know what I mean? I feel like that puts it in a better context that like more people could relate to.
Yeah, sounds
And
like
it's
you
kind
agree
of
with
because
me now.
well, I mean, it's not that I disagreed with you in the first place, and I agree with you on this point. Like I said, I just used it earlier, more meat to chew on, I think. But again, I do think that there are another subset of patients that, like, if I paid a plumber to come over and he's like, yeah, your sink isn't draining. And I was just like, well, are you going to fix it? And he's like, yeah, I'll fix it. And it's like, okay, well, that's all I really care about then. You know, I think it could be the same thing with other people where, yeah, you have non-specific low back pain. Okay, well, are you going to fix it? It's like, yeah, we're going to fix it. It's like, okay, well, then I guess I don't care as long as it's fixed. But I would probably, I would say that more times than not, people want more things to chew on, more specifics, more context to it, kind of like what you've been
I
alluding
think
to.
we also have to consider where we fit in the entire healthcare system. Every other healthcare provider these people are going to see, their primary care doctor, their sports med doctor, any kind of surgeon, their physician assistant, their nurse practitioner, their nurse, every other person uses different language than us.
Mm-hmm.
It is highly unlikely to me that the patient is going to trust us over every single other person that's saying the same thing if we're going to say something different. I know I've made that point already.
What? No
What? I
way.
know, dude. Patients need that continuity of care. For example, how many times do you get patients that are referred to you by the sports medicine doctor with whatever diagnosis, and then you go through all your testing and you say, hey, based on our testing, I totally agree with your doctor. I think it's the exact same thing. And patient's like, okay, great. I love when people are on the same page. Or your patient comes to you and says, I did a lot of research on my own. I think it could be this. But I want to obviously talk to the professional and see what you think. And then after all your testing, you say, yeah, I think that's exactly right. Or like, that's pretty much right, but I'm going to add this little extra bit for you. And they're like, oh,
Mm-hmm.
great. That's awesome. When you have that consistency in labeling, it just makes people trust you more, makes them trust the process more. And if you, as a physical therapist, are the only one that's different in the entire healthcare system, that's a little rough for the patient.
Yeah, and I was just gonna say, yeah, you're the only one different because you're right. That's why. But not
Well,
always the case.
so I would rather win than be right. Like
Yeah.
that's part of my mentality. When I was a younger therapist, I of course wanted to be right because I thought that was really cool.
Yeah.
But the older I get, the more I'm like, what really matters here? What matters here is the patient getting better. Example
Yep.
of that was I am just now actually to the day, June 13th will be my 9th year practicing. I will be learning dry needling on June 13th.
Congratulations.
I waited this
Congratulations.
long to do it because the evidence is like mediocre. I don't need it to get people better, but the market has shifted such that people are referred to PT for dry needling.
Uh-huh.
Patients are getting more exposed to it. They're asking for it. And I am not going to win that battle of like, you maybe don't need it. Like, it's probably fine if we don't do this. It's just better. Like, if you can't beat them, join them kind of thing. It's just like, just freaking do it. People
Come to the
want it.
dark side.
I'm going to still give you all the other things I know are really great.
Oh yeah.
But
Yeah.
but I'm also going to have this thing for you because it meets your expectations. It's meeting
Yep.
this cultural moment that we have in physical therapy and healthcare in general. And if I'm trying to fight that stubbornly, it's just not really constructive. I'm going to be the one that looks bad. And
Yeah.
I care about getting you better and winning. I don't care so much about being right. And so this process of changing the language we use in healthcare, it doesn't happen overnight. It takes forever, decades and decades for language to shift. I mean, think about the language that we use day to day and how we describe gender or like our politics or whatever else you want to think about in life. These words take time to get everywhere and become more accepted on the order of decades.
Yeah. Yeah. Mm-hmm. It's like calling soda pop. Still waiting on that one to come through.
Well, pop is the correct answer.
Yes, correct.
Yeah.
Yeah.
It is correct. Yeah.
Yeah. But the rest of the
It's much more efficient. It's one syllable. There's one less letter. Yeah. You soda doers are wrong.
Yeah, and like that's what I was kind of saying earlier too, in terms of if I called you like you have a red diagnosis and you have a purple diagnosis, if that makes me sound stupid, so be it. Does it make you better? Okay, sweet. I'll sound stupid all day long if that means the patient's gonna get better. Yeah, that's kind of my common theme throughout the podcast. Patient to patient, each variation on how you communicate to them and how you communicate their diagnosis to them. I think that at the end of the day, kind of like you said, does it matter if you're right or does it matter more if the patient gets better? And so if that means you have to put your ego aside a little bit and play ball with what the previous medical provider said, even if you don't fully agree on the diagnosis, and then, if you have to play ball a little bit for the patient to get better, so what? You have to do that. And that's totally fine. But kind of like I said earlier, like it doesn't matter, like as long as the patient's getting better, like I think the some of the best PTs are the PTs that know how to communicate in that way so that the patient gets better in terms of how they're saying or what they're saying they think they have going on.
And that's, to give you an example of that, that's what I do. So, for example, if someone has a bone spur and the patient's concerned about that and we're kind of wrapping up our session and all that, I might say something like, I know your doctor said you have a bone spur and that's causing your issue. Well, that certainly can be happening. You should know that loads of folks have changes to the shapes of their bones and don't have pain. Also, your spur didn't come out of nowhere. It's been there for a long time and you certainly had it when you didn't have pain. Our job is to teach your body how to ignore it again, and we're going to do that by doing these things. So I acknowledge the terminology already used by their doctor in their head, and then I begin to de-escalate and plant these seeds of, this is going to be fine. Like, you're totally going to be good. Here's how we're going to go about this process. And so I think methods like that of acknowledging where the patient's at, the words they're coming in with, and then shifting that conversation over time, and then also helping to get them better with everything that you're doing. That is how you win. And that is how you begin to make the person not so concerned about things like spurs and tears and arthritis and being quote unquote bone on bone.
Yeah. And kind of going back to what our brand's all about, right? Flex Mettle. It's looking at the individual, and it's like what we've talked about before. It is flexing that resilience that they have, even through all of the pain, through all of the scariness, the fears of what could be going on, right? It's trying to make individuals feel comfortable and confident with how they feel in their body at the time. And I think the article even alludes to a little bit of moving past this idea of like fixing. And, are we going to fix the bone spur? Are we going to fix the arthritis? I mean, if there's a PT out there that figured out how to reverse and fix arthritis, they would be a freaking billionaire. But like, is it really so much of the fix, or is it like you said before, Christian? Okay, your body has had this stuff even when you were pain-free. How do we get back to being pain-free, even with what we now know is going on?
Yeah, there's actually a good quote that I wrote down from the article about what you said about fix. Quote, clinicians should use explanations that de-emphasize the need to fix and focus on the modifiable factors within a patient's control, such as physical activity, sleep, nutrition, smoking cessation, and stress management. And yeah, I think that's great. I want to work on all those things, but it's not very helpful. This is me going on a bit of a rant, I suppose, but I think that stuff's great, but everyone knows that. Everyone knows you shouldn't smoke. Everyone knows you have to do more cardio and eat more vegetables. And saying like, hey, you have neck pain and movement coordination impairments. We're going to do these things, but also I need you to really focus on your sleep and your nutrition. It's like, yeah, I get it. I know that. But like, what are you going to do to help me with my neck pain? I'm also not going to sleep more because I have 2 kids and I work 60 hours a week, or it's not a priority for me right now. So that's where you're like, okay, I got to meet this patient where they're at. There's only so many things that I can control and modify. And yes, I'm going to hopefully nudge them in the direction of having better lifestyle habits. But because I will say truthfully, fixing things like sleep and diet and general exercise and meeting those benchmarks we have for strength and cardio, that is the closest thing we have to magic. Like if you do those things, life is better without a doubt.
Yeah.
But if I focus my entire session and interaction with you as being someone who tries to advocate exclusively for those things, I'm going to lose you because it's just it's not the most winning message because everyone already knows it and they're already trying to get to those things. It's just you're going to try to shift their behavior, of course, but you also have to be focusing on the thing that they're there for in that moment. And so an example would be, I know someone has to do more cardio, for example. Let's say they're really good at doing strength training. They go to the gym 2 to 4 times a week, but they only focus on strength or machines or hypertrophy work. They do zero cardio. Well, okay, what if instead of telling them, I need you to run 3 times per week to hit your American College of Sports Medicine physical activity guidelines, what if I said like, hey, what if we start with you taking shorter rest breaks between your sets? What if, your average heart rate before was 90 to 100? Well, how about we try to keep your heart rate to 120 as the floor? And we're going to do that by bringing your rest breaks down from 3 minutes to 90 seconds or 2 minutes at most. And you just keep trying to adjust those rest breaks or go a little bit harder or easier in your sets to keep your heart rate at about 120. I'm just shifting a small thing about what they're already doing and they're already consistent with to get them getting a bit more of that zone 2 or like light to moderate intensity cardio because we know it's going to have all those amazing health benefits. That's just one way I might incorporate these lifestyle changes into someone's already established routine. And eventually, hey, maybe they learn to like it or they feel better. Now we're like, hey, let's talk about actually running now. But I'm not going to win with the message of, hey, I know your neck pain's a thing, but let's also focus on your sleep and your nutrition and whatever else.
Right. Because we know those things are going to be helpful. We know that it's going to help out in the long run, the big picture of it all. If you have neck pain and you go home and you eat some carrots, it doesn't make the neck pain go away. You might have had a healthy snack, but it's not going to magically make the neck pain go away. And kind of to your point, and I think you were, alluding to this a little bit, Christian, but, we need things that we can tangibly give to the patient, like there and now, right? Like you made this point, and I don't know why it stuck with me. We had this podcast probably a couple months ago, and I think about it like almost every day now. And that's the idea that like when we're talking about hip injections for like greater trochanteric pain syndrome. Anyways, let's say we're given a corticosteroid injection because we think like the glute med is having some tendinopathy and we just want to, kickstart something. Well, like we know that in the long run, that exercise, that injections show no superior benefit in the short term, and actually in the long term, exercise and what in education seem to be more superior than injection. Regardless, though, if let's say you're someone who, like me, pretty soon, I'm gonna be living freaking neighbors with the Amish now. I'm moving from in town now. I'm neighboring up with the Amish, and for me, it's not that bad. 20-30 minute drive to work. Imagine if you had to drive 45 minutes, 60 minutes to get to a hospital for your orthopedic appointment, and the doctor comes in and they're just like, oh yeah, hey, by the way, within a year from now, exercise is actually going to be better for you. So let's just wait this out and start doing some strength training, and then the patient's going to be like, oh, cool. I drove 60 minutes one way to be told, wait a year from now and do some strength training rather than being in the office and being like, hey, I'm here. Can we do something, right? If it is an injection or, in PT, kind of the same thing. Most people have extremely busy lives, and sometimes they have to drive very far and put a lot of effort, time, and money into coming in. And it's offering those tangible things. If it's putting your hands on them for manual therapy, offering something like dry needling, right? Maybe going through a nice, good home program list and educating so that you can tell them, hey, go home. We don't need you to come back in for another 3 weeks, right? You got a busy life, long drive, be independent for the next 3 weeks with this, come back in and we'll talk more about it. I think patients appreciate that a lot more than coming in and being like, all right, twice a week for the next 6 weeks and come on in so we can just do our basic stuff and then have you go home. I highly doubt that patients are going to be bought in, motivated, trusting, and that the plan is going to work, because I just feel like that's an older thought of PT. The whole, all right, twice a week for the next 4 weeks, or however many weeks you want to say, so that they can come in and you can watch them do exercises. When it's really, I think majority of people, maybe not majority, but it's like, come in for the eval. All right, we did some tangible stuff today. Here's something I'm going to give you. Have fun for the next 2 to 3 weeks. You don't need to come in twice a week. Like, come in twice a month sometimes is what's best. Sorry, I got on a rant there. I think I got off topic a little bit, but
No, I totally agree. I want to wrap up with, from a different research article that I read related to this one. They had 5 really good questions that we should be asking ourselves when thinking about a diagnostic label for someone. And so the 5 are: will this label help or hurt the patient's recovery? Is this label really accurate, or is it just based on something common in people without pain? Will this label lead to unneeded tests or treatment? Is this label actually helpful for the patient's understanding? And who is this label really for, the patient or the healthcare system? So I felt like that article dropped bombs in numbers 4 and 5, the last 2. Is it actually helpful for their understanding? And then who is the label really for? Is it for the PhD physical therapist who sat around on a table some years ago making up these amazing definitions of movement coordination impairment? Or is it for the patient? Because that is literally the only person that matters, is, do they understand it? Do they like it? Does it help them latch on to the treatment that you're doing? Does it build trust? And if it's not doing that, it's not going to lead to them doing a consistent plan. And so that's all I care about. And when I think about the other questions, like, will this label help or hurt the patient's recovery? That's where I definitely think we should be getting away from things like, you have osteoarthritis or you have arthritis in the knee and it's due to all this wear and tear that you've had over the years. That just sounds bad. And that phrasing, wear and tear, leads people to move less and be more averse to pain. And those things we know are the complete opposite of what we want to do. We want them to feel okay with the pain, to know that it's not going to dramatically harm you, and that actually you need to work through it a bit to truly get better. And so shifting away from those types of words like wear and tear and spur, for example, makes perfect sense. But does the label that we give things need to be the most research or textbook accurate term? No, because you're not serving the patient, you're serving your own ego as the provider.
Yeah, I would, round of applause. I would agree with that. Whoever came up with the word bone spur, like, man, they really did us disjustice on that one. Like, come on. Can you call it like a bone pillow? Like something like soft or
It's like a bony growth. I don't know.
Yeah, a growth. Yeah, exactly. Not this sharp, pointy thing on the back of a cowboy boot that can, cut and tear crap up all the time. Anyways, but yeah, no, I agree wholeheartedly with that. Like, who really is this for? And like, again, at the end of the day, if you're trying to give someone a diagnosis to sound super smart and feed your own ego and whatever else you're trying to do, it's like, are you really trying to serve? Like, who are you serving? Is it for the patient or is it for you? Because at the end of the day, usually when you keep things more simple, when you can provide the patient a little bit of insight so they have some trust in you, and you're not just being a complete dick and totally contradicting everything that every other medical professional they just had told them, usually patients will tend to get better.
Yeah, I think that's a good way to end things. I think we're on the same page. Really, It just comes down to meet the patient where they're at.
Yep.
Use words they understand, but try your best to use language that de-escalates the pain without getting way too jargony and using meaningless terms that they literally don't care about.
Yep. I mean, I don't know who said this quote, but like, isn't there a quote about like, you truly understand something when you can explain it very simply for other people to understand? I think that's like a famous quote from like Einstein or something. I don't know. I might be messing that one up.
No, I think it was either Richard Feynman or Carl Sagan. It was one of those two. But yeah.
Okay. Yeah, I knew
both
it was
legendary educators. 100% listen to them if you want to learn how to speak better and teach people stuff better. I love them.
Yeah, it's the simplicity in it. And yeah, but anyways. Yeah, no, dude. Solid podcast. My apologies if I was going on rants. I think we both might have got a little ranty on that one. but that's fine. It's fun to have those. But yeah, anyways, no, yeah, that's a good article. I think there's so much gray area. There's so many PTs and physios out there. We're probably never going to get everyone on the same page to agree on one thing, right? And like we said, like at the end of the day, just tailor things to the patient and get the patient better. And yeah, who knows? Maybe in our professional career we'll see a resolution to all this, but I highly doubt it. It'll probably be this continual back and forth gray area. But I think these types of narratives and articles are what bring up these conversations to be had.
Yep. All right. Thanks, Eric.
All right, Christian. Thanks, man. You have a good rest of your weekend, and we'll talk to you later.
See ya.
Yeah.